Rahman. I was born in Dhaka, Bangladesh. It's sort of an interesting story. My father was a physician. He never asked me to be a physician, but maybe there were subliminal messages that I got somewhere along the way. My mother, who was not a physician, wanted me to be a physician. But I didn't decide until it was the last moment. I had applied to engineering as well as medical school. In Bangladesh, you go to one or the other after finishing high school. You don't have to go through college. And the day I decided was the day when I had two interviews, one in each place, and I had to make a decision which interview I was going to go to. It's weird, but that's the way it was. My specialty is cardiology. I think that occurred pretty early in my medical school years. And I've always wondered why. And one possibility may be that all the physicians in my town who were looked up to were primarily cardiologists. And I thought maybe that's the way to go. Went to medical school in Bangladesh. I finished medical school and didn't do any other further training there. Whatever was obligatory I did. And then I took a test that was given at that time in Bangladesh and other parts of the world as well. And if you passed that test, you could get an entry into the US and get into a training program here. And that's how I came to the US. It's multifactorial. One of those was that the initial intention was to go to the UK, which is the usual process most physicians follow over there. For higher education, they go to the UK, work there for a year or so, pass a test, which gives them a membership in the Royal College of Physicians and Surgeons, and then they went back to Bangladesh and practiced as specialists, which was my intent, but only the best students could go there, and I wasn't one of them. And the best students would go there because they would get a scholarship, and I realized very early that I was not in that caliber. So I decided, I heard from someone that there's this test you can take that would give you entry to the US if you pass, and that's how I decided to take the test. And we may be talking about 3 times periods. One is my medical school. As you might know, at that time Bangladesh was considered maybe the poorest country in the world, if not, there was no other ifs, ands or buts about it. Yet I think because of that there was hardly any technology available, so we used to have to learn how to examine patients, take histories, and base our treatment based on those things primarily. Although there was some testing, but it was pretty rudimentary. When I came to the US soon after I finished medical school, it was in 1972, the US was much, much further along. And even in those days, people thought that there was too much technology being used in medicine and not enough patient examination, history taking, and the cognitive work that goes behind it. Today, it is a sea change. And in my mind, it's a sea change towards more technology, less patient interaction, even though people might want to say things differently. I trained in cardiology in Miami, Florida. And when I finished, I did invasive cardiology, which is catheterization and other techniques that were available then. And I wanted to continue to do that somewhere. I was offered a job at where I trained, but I didn't want to stay there for various reasons. But I wanted to find a place where I could continue to do those procedures until I found the real place where I wanted to practice. So at that time, the job opening was, I think I saw it in a magazine, a journal, at the VA hospital in Ellesmere. And they had a cath lab, which is what I wanted to do. So I came there, sort of parked there for a while until I found my niche. And I actually continued to do some heart catheterization there. And at the same time, I then came to know the Medical Center of Delaware, the then Medical Center of Delaware, and I called up the chief of cardiology and said, can I come join some of your conferences, and he was very gracious to have me come over. And that's how I got to know the cardiology community here. And while I was doing this, I kind of liked the area, partly because of where it's geographically located. Close to big cities, but not quite a big city. And that's when I decided that I'd probably start a practice here. Practice is quite a different animal. I didn't even know how much to charge for any of my activities. I truly didn't. And you couldn't ask other people either. And that would be a collusion, I guess. And you just came up with an amount that you charge for whatever you charge. And most of the patients were covered by private insurance, offered by their workplace. And I must say that I was not very inclined to look into those things myself. I didn't have a business angle of this thing. And whatever my business manager said was the right thing to do, I just went along with that. Barriers-wise, I really didn't see much barriers. I got opportunities to do whatever procedures I needed to do. Obviously, there were occasional instances of what I perceived to be barriers, which I think we overcame reasonably easily. And it's practice, building up a practice is a fascinating experience. And it's not that what you know about medicine that really makes you a successful practitioner. There's many other things that come into play. And I learned as I went along. It has changed in many ways. Primary care physicians used to come to the hospital. That was a norm. They used to see their patients, and we would see patients along with them as consultants. Now hardly any primary care physician comes to the hospital. So when the patient enters the hospital, the patient really doesn't know the doctor that sees the patient in the hospital. And I think that disconnect is not good for patients. It may be good for efficiency, it may be good for many other things, but for the patient's psyche, it's not a good thing. And primary care physicians, even if I see a patient now that belongs to a primary care physician who's practicing outside, and I want to call the primary care physician up and give some feedback, it's very difficult to get hold of them. They're extremely busy in the office. Getting through their phone lines to them is difficult. We always send paper records to them. But paper is one thing, 1 minute of conversation is something else. In my personal career, there were no major issues. There were some minor things that I don't even want to go into those. But in the landscape of practice of medicine, practice of cardiology, things have changed tremendously. We were in an era where everything was kind of laissez-faire. Fee schedules were open and quite generous. Subsequently, we had all these technology available that was easily available to all physicians, and in fact Christianity did a great job of staying on top of all the recent technology and bringing them into play. Now I think we are in an era where we are thinking that the pendulum is swung too much in one direction, and that we need to really talk about all the things that we are doing. Are they appropriate, not so appropriate, where do we cut back? And the cardiology community in general and the professional organizations are actually coming up with appropriateness criteria for various procedures and tests that we do. And that is becoming difficult for physicians to attune themselves to. But I think they see the writings on the wall, that they have to become more cognizant of what's appropriate, what's not. And I don't mean they do inappropriate things, but some things are more appropriate than others. And trying to find the right procedure or test or treatment for a patient will be more scrutinized, and thus physicians have to retool themselves to take those into account as they practice whatever they practice. Diseases are diseases, they have no geographical boundaries. Some diseases are more prevalent in certain geographic areas than in others. I think the knowledge base is really expanding, and the knowledge of physicians is also expanding because the knowledge base is more easily available. But risk factors for this or that are pretty much the same wherever you go. And you can talk about HIV or heart disease or whatever, the risk factors are similar. And in a world that is becoming so-called globalized, health should be globalized as well, healthcare. More information out there for people who cannot afford it. Preventive care certainly should be the supreme thing to do. Much less expensive, much more bang for the buck, but probably not very popular because most physicians are not in that area of their practice. We need all kinds of physicians people who are experts in global health, people who are experts in local health. The local health people have to depend on global health people to tell them what the extent of this problem might be, because that gives you perspective. And the global health people need to know what the nitty-gritty down at the patient level is that they need to focus on. But I have no question in my mind that there is a gradual, slow, but definite exchange of information among physicians all over the world. And when I go to Bangladesh, I'm sometimes surprised at some of the things that they know, which couldn't have come from any other source other than cyberspace. And that's for the good. My mother, as I said, was not a physician, but she instilled the work ethic. My father was a physician, and he was extremely strict about instilling work habits. And one of the things I learned from him is this ability to, ability to boil things down to the essentials, rather than talking nebulously about things. Just tell me what it is and just get that done. And I think I've tried to practice, tried to use some of that in my life. So he's been very influential in my career as a physician. Learn the basics of medicine. Don't think of technology, think of how a body functions. And once you know how body functions, you might know when the body parts don't function, you know what